blind spots. We had, I think we filled out most of the fill-ins. Anybody that was here yesterday, if there's any fill-ins that you didn't get, let me know, and we can go over those, because I have a ton of notes, and they don't necessarily follow exactly what I have on there. So we talked a lot about blind spots, how they relate to cortical hemisphericity, and I think the last thing I was talking about was when you're looking at blind spots, the lower field of vision is going to correlate more with the parietal lobe, and the upper field of vision is going to correlate a little bit more with temporal lobe. It's just something to help you kind of diagnose a little bit more when you're first getting started, but obviously just with all the other tests, it's not specific just to that one area, it's just correlated a lot more with it. Okay, I think those were your last two fill-ins. So what we want to get into right now is the implications of cortical hemisphericity. So in order for the motor system to function correctly, the sensory feedback and cerebellar input and all that has to be intact. So if you have a reduction in that feedback to either side of the brain or either side of the cerebellum or whatever, you're going to see aberrancies. So if you have a reduction in function of at least one hemisphere, you can see things like altered reflexes, evidence of change in tone, and also something we see a lot is pyramidal distribution of muscle weakness. We'll talk a little bit more about that in a second. There's also been some studies that talk about cortical hemisphericity. So they've done it not necessarily from a functional neurology standpoint, but just from a strictly cortical firing aspect. And they found that children with nocturnal enuresis, depressed adults trying to commit suicide, and also a really kind of interesting finding, 10 out of 11 expert translators, so in linguistics and whatnot, have a rare phenomenon of unilateral hypertrophy in the right inferior turbinate and a straight nasal septum. So what they're finding is that if you have this hypertrophy of the right inferior turbinate, you're awesome at being a translator, which is really strange. But it's just another kind of finding that's showing if one side of the brain is working more than the other, you're going to have asymmetries, and that's really what we're looking for as a functional neurologist, right? We're looking for asymmetries, and if it's working great, awesome. We don't have to do anything with it, but if it's not, we got to find a way to ramp it up. So, yeah, that's all I want to really say about hemisphericity. We'll talk about hemisphericity pretty much in every module. I just want to keep giving you frameworks of how we kind of look at hemisphericity and how it's going to present. So for some of the newer people, we're going to talk a little bit about the impact of spinal manipulation. So as chiropractors, functional neurology started out with chiropractic. And it started out with the application of one sensory modality, one adjustment that causes all these different changes. So for, 100 years, we had seen people come in for neck pain and back pain, but now all of a sudden their asthma gets better, or they were dizzy and now they're not dizzy anymore. And all this kind of stuff that we had tried for years to really understand, and we put all sorts of different techniques together and listing systems and all this, but functional neurology kind of grew out of the research base that recently came up that says that the sensory input is really what's making these big changes globally. So, if you hurt your back and, your back's not moving right and you adjust it, you're just pretty much going to affect the back, right? Chiropractic's good at that. But if you have back pain, but you never had an injury, or, you've never had any history of traumas or anything like that, and you still have back pain and other symptoms, there's a good chance that it's not localized to the back and there's something going on suprasegmentally or in the brain. So taking that concept, Dr. Carrick kind of went along and found out that it's not just adjustments, it can be any sensory modality. And for me, this was a big breakthrough because it really explained to me, like, you had heard of sound therapy or light therapy, or people going in and saying, oh, I had all these problems, and they shine a light in my eye and I'm all better. It's like, well, that's weird, but why does that work for some people and not others? And I had the same questions about chiropractic, right? So now what we're able to find out is that, that light therapy was appropriate for that person because that's what they needed. Or that chiropractic was changed their life because that's exactly what that person needed. So as a functional neurologist, you get to extrapolate and say, I have a spinal manipulation, which no other profession has anywhere. That's good at it. And you're able to take that and say, okay, if the person needs it, I can use it. But if it's not what they need, I have other modalities that other people can use that I'm going to apply in a different way. So we use vestibular rehabilitation, which is awesome. Like, everybody has seen the gyro stim on the news, and everybody's saying we have all this NASA gear to rehab people. And the thing is, you can do most of those rehabs in your office. It's just not as cool and fancy and expensive. But most of those principles you can take care of in your office. So specifically what chiropractic does to the central nervous system is mainly focused on three things. It's going to be on the muscle receptors, the joint kinesthetic receptors, and on your skin receptors. So that just makes sense, right? When you go to make an adjustment, say in the cervical spine, obviously you're activating skin receptors because you're touching their skin. As you make that adjustment, you're changing the tone of the muscle, and you're also changing the joint mechanoreception of the segment that you're working on, right? So, but what you're also doing is, since you're gapping the joint and creating that cavitation, what it does is it brings the joint and the muscles to a place that they never really go to. And since you're doing it in a controlled way, it gets this burst of stimulation that you can't really get anywhere else. So that's kind of why you see those big changes as you go up to the areas of more mechanoreception and more proprioception. So in the low back, you don't see a ton of central changes because there's not a lot of proprioception down there. And as you move up the neck till you get to the top of the neck, the occiput, you have a huge amount of input. And if the person can handle that, and that's what they need, that's the greatest stimulation that we can do as chiropractors. But if they're not able to handle it and you do that, you can actually cause some damage, which is kind of why we modulate it. And just kind of a side note, pretty much everybody I've met that's done functional neurology has gone through what I went through, and you realize that your adjustment can be negative. It can actually cause harm. And so every patient that I first started working on, when I actually got this concept, I was almost afraid to adjust. I was really careful. I'm like, oh my gosh, their eye's a little faster than the other one. I can't touch them. And just realize that this concept of functional neurology applies to all your patients, but there's only probably 10 to 15% that are really severely neurodegenerated that won't be able to handle the adjustment. And we're able to tell that through our testing, but don't be afraid to adjust people as you get farther into this. Because yes, you can potentially cause harm, but the benefit is usually much better to the general population, especially students and stuff. We're generally healthy people. Don't be afraid to work on your fellow students. But just kind of a side note, I've noticed that from almost all of us that have gone through this program so far. We talked about muscles and spindle receptors being really numerous in the neck. They're also extremely numerous in the anti-gravity muscles. So all the things that are intrinsic to your spine, like your multifidus and your rotatories and all those, and also your intrinsic hand muscles. So if anybody's seen a homunculus, you know how big the lips and the hands are. You got a ton of reception in your hands. Okay. Now, for boards, you're probably going to need to know all the different receptors. We're not going to go in depth to any of them, but be aware of the fact that the receptors in the capsule of the joint are Ruffini endings, whereas the receptors around it are Pacinian corpuscles, and then go into learning about what Meissner's are, what Merkel's disc is, hair follicles, all that kind of stuff. Really boring, not really that practical for us, but things you're going to need to know on boards. So just be aware of the different receptors and just kind of review them a few times, and you guys should be good to go. Just a quick note, for maintaining balance, your spine gets a large amount of its input from the cranial-cervical junction, which is what we talked about, the upper cervical neck occiput area. So this is also where your tonic neck reflexes come from. So you'll learn, I think it's pediatrics, you start learning about all the primitive reflexes, and if you go to, was it reflexogenic systems? Reflexogenic systems is like 805. You learn a lot about the different kind of infant reflexes, and if they're still present, that means something's not going on correctly in that person. You learn how to rehab them. Just kind of a side note. And then also about adjustments, they've been found to improve non-specific deficits in visual perception. So going back to the blind spots, you remember when we talked about the fact that you have a physiological blind spot, but there's also or an anatomical blind spot, but there's also a physiological one. The adjustments through that Carrick study have shown that you can improve that eyesight and improve the size of the blind spot just through spinal manipulation or adjustments, or whatever you want to call them. And then finally, on adjustments, we'll talk on Mondays about the central integrative state. So for any of the upper quarters, you know that the central integrative state is essentially the health of either a neuron or a but the central integrated state of the cortex. So if your brain is maintained through the somatosensory input from the cerebello-thalamo-cortical tracts. So when we talked yesterday, you guys remember the space astronaut analogy that I made about the fact that so much input comes in through your proprioception and anti-gravity muscles. So not only does that contribute to your cortical health, it's also between the cerebellum and the thalamus and the cortex. So they have this big loop that comes from your cerebellum, goes up to the thalamus, synapses in the cortex, and goes back down. It's this big loop. So a lot of times you'll see when somebody has, say, a right cerebellar lesion, they're more probable to have a left brain lesion also because of the high amount of connections between those two different systems. So for some of the lower quarters, that's something to keep in mind. The good news is your proprioception comes up on your one side and goes over to the other. So if you're adjusting somebody for a right cerebellum, left brain, and you adjust on the right side, you're hitting both areas. So that's kind of a good thing for us. And then finally, the last thing I want to talk about is the descending cortical influences from the brain to the muscle receptors. So you have neural signals sent from your central nervous system to the gamma motor neurons, and that's going to regulate the spindle activity. So it regulates basically the gain. So, as your muscles become more sensitive, your gain decreases. And as your gain increases, your sensitivity decreases. That's something to be really, commit that to memory. So as gain increases, sensitivity decreases. As sensitivity increases, gain decreases. Yes.
What is gain?
So gain is, just think of it like distortion. Okay? So if you want a lot of input coming in from your muscle spindle receptors, you want a high amount of sensitivity. If you want to kind of dampen them, you want a higher amount of gain. And we talked about that yesterday, about the GTOs and the inhibition of the gamma motor neurons. And the other thing that's just kind of a trivia thing is the only clear monosynaptic output from the brain is the lateral corticospinal tract. And everybody knows that that's what controls mainly your volitional movement. So if I want my right arm to move, the track from my left brain to my right arm is straight. We can trace it. Everybody learns it in class. That's the only monosynaptic one that exists. Everything else is integrated. And that's why we're able to use the functional neurology to affect different areas. So it's kind of cool. It's like you'll learn in embryology that you have these homologs that develop together. So there's a bunch of cranial nerves that exist together, and what you find out is that whatever grows together is what fires together. So, say you want to activate cranial nerve 3, which is your ocular motor nucleus. We also know that there's other cranial nerves that fire with that. So if you're having problems with your ocular motor nerve and the mesencephalon's a little ramped up or not firing correctly, and you want to activate it without doing eye movements, you could do, say, tongue movements, because we know that those fire together. It's like, that's crazy to me. Like, I had no idea you could do that kind of stuff. But for people that are really, really sensitive, you can use that kind of therapy so that you don't, blow them out and kill all the neurons, but it still rehabs that area very slowly till they can get up to a point where they can use eye movements or can handle an adjustment.